Hi, this is Steve Trion. I'm a professor of medicine at Harvard Medical School and the director of the Bing Center for Waldenstrom's Macroglobulinemia at the Dana-Farber Cancer Institute in Boston, Massachusetts. I also just served as the co-chair of the 11th International Workshop on Waldenstroms and the co-chair of the consensus panels that took part at this meeting. I have the pleasure today of telling you a little bit about the deliberations of the consensus panels at the 11th International Workshop on Waldenstroms. There were, in fact, 7 consensus panels, and it's important to note that the updates in the diagnostics, treatment, and response criteria that were included in these consensus panels were probably the most in-depth since the second international workshop that took place in 2002. So in over 20 years, you'll see, considerable amount of updates that took place. Now, the first consensus panel actually was tasked with updating the management of symptomatic treatment-naive patients. This was led by my colleague Christian Buske in Germany, along with Jorge Castillo, from the United States, and Judith Trotman from Australia. You'll also see in this slide that this was a very diverse panel of international experts in Waldenstrom's macroglobulinemia. And these are the key points that came out from the deliberations. For the first-line treatment, chemoimmunotherapy regimens such as dexamethasone, cyclophosphamide and rituximab, or bendamustine rituximab continue to play a central role in managing Waldenstroms, as they are effective, fixed duration, generally well-tolerated, and affordable therapies. But also to keep in mind that covalent BTK inhibitors, such as ibrutinib, zanubrutinib, and acalabrutinib, offer a continuous, generally well-tolerated alternative for the primary treatment of Waldenstrom's patients, particularly those unsuitable for chemoimmunotherapy. In addition, since a phase 3 randomized trial that was updated at the 11th International Workshop showed that zanubrutinib was less toxic than ibrutinib and induced even deeper remissions, this led to the categorization of zanubrutinib as a suitable treatment option now in Waldenstrom's macroglobulinemia. Now, these are the trial designs for the ASPEN trial that actually led to this recommendation. Keep in mind that there were 2 cohorts. Cohort 1 actually treated MYD88 mutated patients. Cohort 2 treated MYD88 wild-type patients. Now, in cohort 1, the patients were actually randomized to either get zanubrutinib or ibrutinib, whereas in cohort 2, only zanubrutinib was offered. So what did we learn from this trial? What we learned was that both of these covalent BTK inhibitors are effective in MYD88 mutated patients. They produce similar levels of major response, but numerically far more very good partial responses were recognized with zanubrutinib. But I think even more impressively with this update, we saw that zanubrutinib was active even in MYD88 wild-type patients. This is important because 65% of patients attained a major response, and we had not seen this with single-agent ibrutinib in the pivotal trial. In addition, when you look at the adverse events that were updated for cohort 1 at the 11th International Workshop, you actually do see big differences. Far less atrial fibrillation associated with zanubrutinib, but you do see more neutropenia, including grade 3 neutropenia associated with zanubrutinib. So important to keep in mind that there are differences in side effect profiling for these 2 agents. And I think it is important overall to note these differences when one is considering which one to apply to a particular patient. Now, another very important point that was discussed in this deliberation was how we position BTK inhibitors relative to chemoimmunotherapy in treatment-naive patients. And it's important to keep in mind the study by Dr. Abakun from the Mayo. That was a retrospective study, but nonetheless a very important one because it was a large international collaborative study. And the bottom line is it showed that even though you can get deeper responses with bendamustine Rituxan over ibrutinib, progression-free survival and overall survival differences were not seen, and this was with a median follow-up of 4.2 years. However, also updated at the workshop was the work by Konstantin Tam that was a biomarker analysis of the ASPEN study. And I think here we learned something very interesting. Though TP53 mutations were previously reported to be rare in treatment-naive patients, they certainly are not rare when it comes to previously treated patients. And this was the message by these biomarker studies. Most of these patients, in fact, had had an alkylator agent as their prior therapy. In fact, over 80% did, and even up to a quarter of the patients had a nucleoside analog. So it is important to keep in mind that perhaps being exposed to alkylators or nucleoside analogs may have led to this increase in TP53 alterations. And previous studies, even in Waldenstrom's, had shown that these TP53 alterations were associated with poor survival and worse outcome. In this study, we also did learn that they tended to do better if they had TP53 alterations if they got zanubrutinib versus ibrutinib. This panel also discussed the importance of MYD88 and CXCR4 mutation testing, and it was advised that both of these mutations should be obtained, particularly before treatment initiation, because both of these are important in terms of their impact on treatment, particularly with covalent BTK inhibitors, and may help you with your choice. And this is just some of the data that was also updated at the 11th International Workshop, showing, in fact, that if you look at the progression-free survival, there are differences based on MYD88 and CXCR4 mutation status. The same with a upfront trial in treatment-naive Waldenstrom's patients with ibrutinib monotherapy. But also, we did see one very important study that was updated around ASPEN, and that was the impact of CXCR4 mutations. This was a bit of a surprise because the patients who had CXCR4 mutations actually did better with zanubrutinib versus ibrutinib. There were more deeper responses, and also, as you can see here, big difference in progression-free survival favoring zanubrutinib. So these are very important lessons that can come, that we can know when we have MYD88 and CXCR4 mutation status. In addition, there was also a very nice update by our colleague, Dr. Matthias Rummel, on the STILL study that looked at the impact of maintenance rituximab. Now, this was deemed a negative study. These were all patients that got bendamustine Rituxan, and if they were a major responder, they went on to then get maintenance rituximab or were randomized to observation. However, when you do a deeper read of the results through an unplanned analysis, you see, in fact, that the patients over 65 and those with a high prognostic score for Waldenstrom's, the IPPS-WM score, they actually benefited with maintenance rituximab. And so it's important to keep this in mind as one looks at, applying maintenance Rituxan to patients. And this is the data that actually showed, in fact, the reduction in risk of progression in the older patients. Similar results were also seen in those patients with high prognostic scoring. Now, other key points of consensus panel 1 were on treating specific morbidities. You'll read all about this in the consensus panel reports. Consensus panel 2 was tasked with management of relapsed or refractory Waldenstrom patients. This was led by Dr. Shirley Desai from the UK, Jeff Mattis from the United States, and Dr. Kastridis from Greece. And I think the important take-home here was that if a patient had been treated with chemoimmunotherapy, that covalent BTK inhibitors were important options. And one should keep in mind various aspects of the patient's presentation, comorbidities, their fitness, what drugs they've seen previously, what their preferences are, what their hematopoietic reserves might be. and also their mutation status with MYD88, CXCR4, and TP53 when making treatment decisions. Of course, keep in mind that if you're going to be thinking about a covalent BTK inhibitor, keep in mind risk for atrial fibrillation, bleeding risk, concurrent medications as being mitigants for which one you choose. Mutational status, particularly MYD88 and CXCR4, can be important, as also now we've learned about TP53. And we also did talk about the options after BTK inhibitor failure, how to manage these patients. And so you'll be seeing these updates as well in the consensus panel reports. Now, what I'd like to do now is talk a little bit about the outcomes from the third consensus panel. And this had to do with recommendations for molecular diagnostics. This was a very interesting consensus panel. It was run by Dr. Ramon Garcia-Sanz and Marzia Berrettoni and Zach Hunter. So what was important here as a take-home is the importance of appreciating not only MYD88 and CXCR4, but now TP53. And also keep in mind that the status of 6q and 17p alterations are also important. Keep in mind that if you really want to go look for MYD88 mutations, use PCR. You can miss a lot of them with next generation sequencing. And with CXCR4 mutations, keep in mind that a lot of them, these mutations can be missed, particularly in patients that have low disease burden. And so ideally, next generation sequencing should be used because there's over 40 different types of CXCR4 mutations, and best to send them to a specialized center for diagnostic workup. Now, Consensus Panel 4 was also very interesting. I had the opportunity to chair this panel along with my colleague Alessandra Tedeschi and Roger Owen. What we did as part of this consensus panel is to first distinguish IgM-MGUS. There are patients actually that present with IgM-MGUS that only have plasma cells, whereas other patients with IgM-MGUS have predominantly a clonotypic B cell presentation. And these actually have different trajectories. There are the IgM-MGUS patients that tend to go towards IgM myeloma, and the ones that are IgM-MGUS that have B cells tend to go towards Waldenstrom's macroglobulinemia. Keep in mind that those that are plasma cell centric tend to be MYD88 wild type, whereas those that have monoclonal B cells tend to carry the MYD88 mutation. Now, in addition, in this consensus panel, we also talked a lot about minimum cutoffs. Meaning that, there are actually publications out there that suggest that you don't have Waldenstrom's until you have 10% disease burden or have, an IgM level above 3,000. But when you look at, frontline clinical trials that, have been adopted for the treatment of this disease, you see, in fact, that many patients require therapy even with levels of disease less than 10% and IgM levels less than 3,000. So this is why, for purposes of making the Waldenstrom's diagnosis, these sort of minimum cutoffs should not apply. What should apply is for the Waldenstrom patients, seeing a infiltrate in the bone marrow, knowing that they have a monoclonal IgM protein, and then distinguishing whether they're symptomatic or not. And this was updated in this consensus panel report. Now, we also had the opportunity to update the response criteria. These were problematic because there were criteria out there that required for patients that had extramedullary disease a continuous assessment, but there was no clear guidance on how to incorporate these serial changes into the overall responses. In some cases, particularly with very good partial responses, the old criteria mandated that all extramedullary disease go away. In the modified criteria that then followed, mandated a reduction, but no clear definition of what reduction meant. So in this panel, we also considered simplified response criteria. This being looking at response, but only using IgM for most of the criteria except for CR. I'll come to that in just a second. And we looked at the Aspen study for guidance because all this data very nicely was documented. And at the end of the day, this is what we learned, that if we just followed IgM, the patients showed similar responses as those that had modified or standard criteria applied to them. And this was true of both cohort 1 and cohort 2 in the Aspen study. And you can see, in fact, that even the progression-free survival curves didn't differ very much. And so why not use a simplified criteria where the patients aren't subjected to recurring imaging? And many patients actually don't want this. And sometimes it's difficult to even get patients in clinical trials because it mandates having to come back and have this additional imaging. Now, for CR purposes, this is different. In a CR, regardless of which criteria one uses, you do want to see absence of extramedullary disease. Of course, you also want to see normal morphology without any evidence of LPL involvement in the bone marrow biopsy. You want to see that the serum IgM is within normal range, and you don't want to see a monoclonal IgM protein. Now, consensus panel 5 was run by Evangelos Terpos from Greece, Andy Brannigan from the US, and Veronique Leblond from France. This actually dealt with recommendations on COVID-19 prophylaxis and management in Waldenstrom's macroglobulinemia patients. There were, in fact, a lot of key points that were generated, including the recommendations for boosters. This is important because when you look at how patients do with regard to response to vaccination, they do much better if they get boosted. And this was the finding among several studies that were reported at the 11th International Workshop. So it's well worth reading these recommendations. Consensus Panel 6 actually dealt with management recommendations in patients with Waldenstrom's that have amyloidosis. This was led by Giampaolo Merlini from Italy, Shana Sorosiak from the US, and Monique Minima from the Netherlands. And there were very important key points to this consensus panel regarding the diagnosis and management. I think what was also very important here was to provide recommendations on making sure that the patients didn't have transthyretin amyloidosis, criteria for actually gauging therapeutic response based on light chains was also advocated. And the key points for Consensus Panel 6 are all summarized in the Consensus Panel 6 report. Lastly, I just want to talk about Consensus Panel 7. This was very important. It was led by Constantine Tam of Australia, Prashant Kapoor of the US, and MJ Kirsten of the Netherlands. This was an important consensus panel because we needed priorities to be established for novel clinical trials. You can come away with the fact that there are, in fact, a lot of clinical trials going on in both Waldenstrom's and IgM-MGUS patients. I'm not going to summarize each and every one of them, but the Consensus Panel 7 actually provided guidance on what we should be prioritizing, including limited duration novel combinations and sequential use of novel agent chemoimmunotherapy combinations as a priority for the next generation of trials. And also discussing what the endpoint should be. You know, what should we be looking at in terms of benefit for individual patients? And with that, I'd like to thank you so much for listening and for having the opportunity now to go to the seminars in hematology and to actually read up on these very important consensus panel reports from the 11th International Workshop on Waldenstrom's macroglobulinemia. Thank you for listening.